AHA stands for American Heart Association 2019 give the definition of transient ischemic attack as episodic of neurological dysfunction due to the focal brain spinal cord of retinal ischemia without acute infarction or the tissue injury. An event that leads no clinical or imaging trace of infarction is considered as TIA. One third have stroke in 5 years. TIA has a prognostic indicator of stroke, which have one third have the stroke in the 5 years, incident approximately 4 lakh per year in the USA. Patient with TIA has a 3-month stroke risk of 10.5%, equal to a recurrence rate following the stroke. 50% occur within the 48 hours. As we know, the new definition of TIA is now tissue-based. The advantage of tissue-based definition of TIA and strokes include the following. The endpoint is biologic, that is tissue injury as confirmed or excluded by neuroimaging rather than the arbitrary 24-hour. The definition encourages us of neurodiagnostic tests to identify brain tissue, brain injury, and its cause. The presence or absence of ischemic brain is more accurately reflected. We should know the other term known as minor stroke. It is an ischemic lesion which is not visible on the brain imaging is known as TIA, and a patient with transient symptom who has an ischemic brain lesion on the imaging is known as minor ischemic stroke. Minor stroke by the absence of persistent neurological deficit that is potentially disability, that is NIHS score less than 3. Since TIA and the minor ischemic stroke generally have the same clinical manifestation, but they are clinically considered together except of the neuroimaging finding. Risk factor of TIA or stroke, which are the fixed risk factor and modifiable risk factor. Fixed risk factor are age, gender, race, previous vascular events such as myocardial infarction, stroke, peripheral vascular tissue, peripheral vascular disease, hereditary, and high fibrinogen. Modifiable risk factors are blood pressure, cigarette smoking, hyperlipidemia, heart disease, diabetes mellitus, excessive alcohol intake, estrogen-containing drug such as OCP. Pathogenesis of the TIA is caused by artery to artery emboli, which may be that is ulcerated atheromatosis, plaque debris from the proximal neck vessel, or cardiac emboli. TIA is usually the result of microemboli. TIA may be caused by a fallen cellular perfusion. Rarely, subdural hematoma is episodic indistinguishable from the thromboembolic TIA. Increased total red blood cell volume, such as polycythemia, may also be the causative factor. This is the pathogenesis of TIA, on which there is decreased oxygen, there is decreased blood flow to the brain, which leads to the decreased oxygen level, which leads to anaerobic metabolism to maintain the ATP. During the anaerobic metabolism, ATP is decreased in production, such as we know, in anaerobic metabolism, there is only 2 ATP generated in the glycolysis cycle. So what decreased ATP do? It continuously activates the calcium channel in the postsynaptic membrane, which leads to excessive release of glutamate. Excessive glutamate release leads to neuronal injury. It is also known as neuronal toxicity. As we know, as in Huntington's disease, it is the main pathogenesis to cause the disease. Clinical features of the TIA. A key problem with the diagnosis of TIA is how to determine if the symptoms are caused by ischemia when brain imaging is normal. Typical TIA is characterized as transient focal neurological deficit localized to a single vascular territory. The clinical characteristics are considered to be the atypical of ischemic attack include the following: gradual build of symptom more than 5 minutes, march of symptom from one body to another, progression of the symptom from one type to another, isolated disturbance of vision in both eyes characterized by the occurrence of the positive phenomena, isolated sensory symptom with remarkably focal distribution such as the finger, chin, or the tongue, very brief spell less than 30 seconds, isolated brain symptoms such as hearing loss. Patient with the atypical attack who have the active brain infarction on diffusion weighted MRI is approximately 10%. What should we do for routine blood investigation. We should go for complete blood count, biochemistry panel, basic coagulation studies. These tests are useful to exclude TIA mimics. Example, hypoglycemia can help to identify the least common cause of thrombotic events such as polycythemia vera. A fasting lipid profile also is appropriate. On neuroimaging, immediate diffusion weighted MRI assess the current preferred test for patient with a suspected TIA, since its sensitivity in detecting brain ischemia is much higher than the CT. In up to 50% of the patients with suspected TIA, a bright spot on diffusion weighted imaging indicates ischemia. Although the CT of the head generally cannot be used to diagnose ischemia when diffusion weighted imaging is not available, CT should be performed to rule out another cause of the symptoms such as hemorrhage. A systemic review found that diffusion-weighted MRI detected corresponding appropriate ischemic lesion in 16 to 67% of patients with classically defined TIA, time-based TIA. On other evaluation, extracranial and intracranial artery assessed with non-invasive imaging such as carotid artery USG, CTA, or magnetic resonance angiogram of the cervical vessels and the intracranial vasculature to diagnose stenosis, occlusion, or both. We should go for tube-lead ECG. In the patient in whom the original TIA is unclear after the initial brain imaging and ECG, further evaluation may include prolonged cardiac monitoring such as Holter monitoring or the use of implantable cardiac monitoring device. Contrast TT and trans-esophageal echocardiography to detect the cardiac structure elements such as the patent foramen ovale, atrial thrombus, and valvular disease or atherosclerosis of the aortic arch as a source of cerebral embolism may be performed. What are the differential? TIA may alternatively accent transient neurological symptom. The most important and frequent cause of discrete self-limited attack includes seizure, migraine, or syncope. Less frequent cause are peripheral vestibulopathy, pressure or position-related peripheral numb, metabolic perturbations such as hypoglycemia, and hepatic, renal, and pulmonary encephalopathies, transient global ischemia. Risk stratification. Treatment to prevent a recurrent, potentially more severe ischemia event is the main initial goal and is guided by risk stratification. The score on the ABCD2 scale is used to predict the risk of stroke. Immediate hospitalization of the patient with ABCD2 score of 4 or higher, but up to the 8 days for evaluation in the patient with a score lower than 4, provided that aspirin was immediately initiated. ABCD score denotes age, blood pressure, clinical features, duration of the symptoms, and diabetes. 0 to 3 score is low risk category, 4 to 5 is moderate risk category, and 6 to 7 is highly risk category to develop the stroke. On the treatment, time course analysis of randomized trial on the effect of aspirin on TIA published in Lancet 2016. Aspirin 300 or 325 given immediately if TIA is suspected in addition to obtaining medical attention. Patient with a TIA not sent home for the emergency department with advice to add aspirin to the next prescription. They should be treated acutely. Urgent treatment after TIA with aspirin reduces the risk of stroke by 80%. Intracranial hemorrhage is rare in the patient with TIA symptom, which is less than 0.1. American Heart Association advice aspirin should be continued at a dose of 75 to 100 mg per day for 90 days. For non-cardioembolic TIA, if ABCD square is more than 4, aspirin should be given 300 mg stat, clopidogrel 300 mg stat, and for 21 days. For less than 4 score of ABCD2, aspirin 300 mg stat with aspirin 75 mg OD for 90 days. We should give. 2019 update of the 2018 AHA guideline in the patient presenting with non-cardioembolic minor ischemic stroke who did not receive IV alteplase or with high risk of TIA, ABCD score more than or greater than 4, treatment with dual antiplatelet therapy, aspirin and clopidogrel, should be started within 24 hours after symptom onset and continue for 21 days, is effective in reducing recurrent ischemic stroke for a period up to 90 days from the symptom onset. It is a class 1 recommendation and level of evidence is here. Previous trial have shown the anticoagulant treatment was not superior to aspirin in the patient with non-cardioembolic TIA or stroke. If atrial fibrillation is detected after the TIA, the oral anticoagulant treatment should be initiated without the delay. Treatment of associated risk factors. In the patient with TIA, long-term treatment involves blood pressure lowering and lipid lowering therapy and control of diabetes. Smoking cessation and lifestyle changes are also recommended. Target blood pressure is less than 140 by 90 mmHg. Intensive statin therapy is recommended when a atherosclerotic origin of TIA is presumed, regardless of baseline LDL.